Thank you all for coming to the Midsummer Town Hall. I appreciate everybody being here today. The summer is a very busy time. We're closing out our work to prepare the budget for the following year, trying to look at our budget performance for the current year to date, assessing where we stand with operational plans, our existing remaining opportunities, as well as thinking about how they feed into the next year. And oh, by the way, it also happens to be the busiest season for healthcare. So there's a lot going on. I recognize that. Let me just say up front, I appreciate everybody's ability to juggle all of those things and continue to help us be successful. What I want to talk about today, as usual, some recognition. I could recognize everybody in this room and all across the campus, but I pulled out a few people to recognize today. As is also custom, just talk a little bit about the high-level financial results, where we stand year to date. A quick update with regard to construction, where that stands and where we stand in terms of physical capacity, particularly for inpatient care, and what the next few months look like on that front. And then I want to talk for a while about change. Certainly I've talked about that in previous town hall meetings, had the opportunity to discuss a lot of things about change, what's driving all of this change around us, how we're thinking about it and how we're responding. What I've tried to do with this particular presentation is, at a high level, talk about all the stuff that's happening. What's driving us to think about doing things differently? And then at the end, I have some of my thoughts, mostly, recommendations or advice back to the institution about things we should be considering as action opportunities in response to what's happening around us. So we'll move through that again. That's where I'll spend most of my time today. First of all, congratulations to our two winners of the Outstanding Teaching Awards from the Regents, the Rhoda Awards, Regents Outstanding Teaching Awards. Two is as many as were recognized at any UT institution. So we have lots of really great educators here. A number of them have already been recognized with this award, but it's a great pleasure to see Dr. Chate and Dr. Peak recognized for their excellence, their great history in terms of providing education to students and trainees, and we're very pleased that they achieved that recognition by our Board of Regents. Dr. Utsi earned recognition as one of the Piper Professors. The Minnie Stevens Piper Foundation recognizes 10 highly successful educators from across all the higher education institutions in Texas on a yearly basis. We've had Piper Professors previously, but if you just think about all the people serving as faculty members at higher education institutions in Texas, and you think about choosing the top 10 of those, it's a daunting challenge, and it is a significant recognition to be honored as a Piper Professor. So these three certainly well represent our educational mission, what we're doing for our students and trainees, and I just wanted to point out to you that they have been so recognized. How about a hand for them? I know you didn't want your picture up there, but had to say happy retirement. And we have a reception coming up to recognize Donna next Thursday in the afternoon. What we've tried to do, I know she's just going to hate all of this, but we'll have a few speakers, people who have had significant relationships with Donna in their career, just to set the tone. And then what we really want to do is provide an opportunity for as many people as possible to come by and share your thoughts about her and what she's meant to the institution. So I know she's not going away. We're not going to let her do that. But she's moving to the next phase in terms of her thoughts about making contributions to improving health, not only at UTMB, but around our state and around the nation. She certainly is one of the most accomplished, administrators in academic medicine in this country. She's regularly recognized for her achievements, and I think it's only fitting that we spend some time honoring her and thanking her before she runs out the door waving goodbye. Also, Dr. Tim Harlan is here. Tim, stand up, please. He is stepping into Donna's shoes. He's already here and working and beginning to drink from the proverbial fire hose in terms of learning about what we do with healthcare and all of the relationships between the academic enterprise and health system and institutional support. And he's dived right in. It's really been great to see. He came with incredible references from Denver Health. I think he was recognized by their mayor, their county government, the state, a lot of different groups for the contributions he made to serving the effort to improve health, particularly for the underprivileged and underserved. You all have seen his credentials. He has a very broad experience, including correctional care, running emergency medical services, a trauma center. So he's just a perfect fit for us, Tim. We're so glad that you're here. And I think all of us in this room will tell you if there's anything that we can do to help you come aboard, we all would love to do that. So welcome. Glad to have you here. All right, so here's the financial statement in the format that we typically use to project the high-level results. And remember, on the left-hand side, we have our actual results from the last fiscal year, 2018. To the right of that, we have the fiscal year results to date. Then we have our budget for the current fiscal year, and then we look at the variances. Variance to the previous year, so we understand how we're stacking up relative to where we were at this time last year, and then variance to budget. And that looks at the major components of the organization, so the academic enterprise, health system, and institutional support. Because this has gotten a little more complicated, we've used the stoplight report here. And so if you come down then to adjusted margin, you see including TRB impact in the middle of the slide, and adjusted margin excluding TRB impact. That's the addition to this slide. A few months ago, the UT system surprised us and decided that it would no longer allow us to use the tuition revenue bond monies that come to us. Those are appropriated by the legislature to serve our capital construction needs. They no longer would let us count that as revenue, routine revenue coming into the institution. Now, I thought that was a really stupid thing to do and roundly criticized them, particularly do it in the middle of a fiscal year. I'm just being facetious. Actually, Ms. Sadro did that. There's a sound reason for that. What they're saying is, that's not truly operating revenue. It is truly dedicated to capital investment. And what they want to do going forward with each of the UT institutions is to look at operating revenue, because truly that is the basis for our financial standing, our bond ratings, our ability to borrow money, secure funds to invest for the future. So they have a good reason for it. It just surprised us that they did it in the middle of a fiscal year. They're allowing for us to account for it separately. You see it's an 11.8 million negative impact to our financial results. So we'll account for that going forward. We'll do the same thing in FY20 because they didn't provide this change information to us quickly enough to incorporate it into our FY20 budget. So we'll continue to demonstrate like this, the separate TRB impact. They won't hold us accountable, if you will, for this change until FY21. But if you look then down here at adjusted margin excluding TRB impact, you see we're green. That's the variance to budget. We're still a little positive. We had a really crummy June, unfortunately, but that's not uncommon. It seems like between April and August every year we have 1 month, which is a little unusual in terms of being more negative than we projected. We hope it's not a trend. We'll certainly see. thus far, at least based on what I'm seeing, volumes are back up and it looks like we're doing better. So we think that was just a one-time combination of events. So essentially, bottom line to me, we're tracking on target to our plan, and that's a good thing. That's what we want to do going forward. Anything else, Ms. Sador, you want me to say? So thank you for that hard work. Now, she would berate me if I didn't say that doesn't mean we can spend willy-nilly for the rest of the year. So we need to stick to the plan, continue to invest as we plan to do, so that we close the year with the sort of financial result that we need to achieve. And of course, then that allows us to continue to make investments going forward. All right, so facilities update. The Health Education Center is open. It's beginning to function. From my perspective, it is absolutely beautiful. I am so proud of that building. I also want to apologize to our educators who moved into the building, because we did that under my authority with sort of a command and control approach. We were operating with a very short timeline, bringing together programs that really hadn't worked very closely together and forcing them to share a brand new resource with which we have no experience. I know some feathers were ruffled by that approach. I apologize for that. I think the good news is we're in the building now. The programs are beginning to function. We have an opportunity now to gain experience together and reset and move forward to optimize the use of that marvelous resource to educate our students and perhaps residents and those of us who are in practice as we move forward and think about all of its potential applications. So very excited to have that online. We're moving forward, and I think that essentially there are tremendous opportunities for us in terms of improving education for our students and others as we deploy that building and its capabilities. In League City, we added 6 acuity adaptable ICU beds May 20th. Now, what acuity adaptable means is that we can do routine medical surgical care in that bed, or we can provide very acute ICU level care. That's something that's desirable. It's wonderful for us. It provides operational flexibility, but it's also great for the patients. Sometimes patients come in, we expect we're going to do pretty routine procedural care, something happens. The patients develop a complication. When you have acuity adaptable beds, you don't have to transfer them to the ICU. You just change the level of care in place. That's a big addition for us at that site to provide more support for more complex procedures that we plan to do there, and in addition to provide support for what MD Anderson would like to do there. We need those acuity adaptable and ICU level care beds. So moving towards that, we'll bring the total number up to 37 in terms of overall number of beds on September 1st. And then as we complete our expansion that's underway up there, we'll have close to 100 beds in the spring of next year. So a little bit less than a year from now. In Clear Lake, we continue to do very well in terms of executing our plan. We added 14 beds in June to the original 70 that we opened in March. And we plan on adding another 43 beds. And when I say add beds, earlier we were staffing those. We have that space already, bringing our total to 127, which will allow us to continue to expand operations there, further engage our faculty physicians and providers, as well as further engage community physicians who are practicing there, who would like to practice there over the course of time. In Angleton, we finished our new CT suite. Thanks to all of you in Angleton who tolerated the construction and the temporary CT scanner that came in on a trailer. It was brought in, I think, once a week and then taken away again. So anyway, we're beyond that now. That's in place. It adds a marvelous piece of capability to our imaging capacity there, so we're very pleased about that. All right, so here's the part about change. We've talked before a lot of our change is occurring across every aspect of what we do. No matter where we individually work, in institutional support, in education, in research, in patient care, some combination of those, change is a fact of life. And as humans, we hate change. And in an institution like this, where we have a lot of really bright people who are constantly optimizing their working conditions to achieve what they perceive as an ideal outcome, when we ask them to change, sometimes they go bonkers. And that's understandable. At the same time, as an academic institution, we're supposed to be leading change. We're supposed to think about our vision statement. Part of our thought is we will help design the future of health and health care through our work in education, research, and patient care. And so, even though sometimes it's really hard for us, we need to be leaders in terms of understanding what's happening around us, designing models that take all of those changing variables into account, and demonstrating that the models that we're creating can do something to improve education, research, patient care, or some combination. So I just want to talk today about what I see happening. Now, this is heavily focused on the clinical marketplace, although it has implications for education and research. Dr. Torres occasionally beats up on me. He says, "Calendar, you hate research, don't you? How come you never talk about that?" That's not true. But what really drives our financial outcomes is the clinical care that we provide. Occasionally I run into a research faculty member who doesn't believe me when I tell them that for every grant dollar we bring into the institution, UTMB adds another 50 cents. Research is a net loser for us. Education is also, although the extent of the loss on education is roughly a dime to 15 cents. Unfortunately, we don't have the state support that was present 15, 20 years ago to fund the academic mission. And so now we're left with funding most of that need, creating those balances, making those institutional investments with what we generate in clinical revenue. And we've been able to do that pretty well, although given our market position, our payer mix, which is important for us to keep because of the sort of service we provide, it sometimes has been challenging. Well, now going forward, related to a lot of the changes that are occurring, it seems that it will be more challenging. We've talked before that revenue per unit of clinical service is diminishing across the country and certainly in our marketplace. And we see that when we look at the graphs of RVUs and other measures of clinical productivity. We see that the dollars per RVU are going this way, while the numbers of RVUs are going that way. And that's driving our faculty and providers crazy. I'm working harder and harder and making less and less. What's the deal with that? I hate that. And to some extent, that's driving burnout here and across the country. So what I wanted to do today is just really talk about some of these overall market trends and some of my thoughts about how UTMB addresses those and plays its rightful leadership role in terms of not only accommodating change, but leading change. And the real reason to do that isn't financial performance. It isn't operational efficiency. It's to benefit our patients and patients around the country. Healthcare is far too expensive. I'm going to talk a little bit more about this when I get into the slides. We need to reduce the cost of care at the global roll-up level and certainly at the level of the individual patient. The way the market is going, patients have much more individual responsibility than they used to. And it seems that trend will continue. The number of personal bankruptcies in this country related to medical expenditures is skyrocketing because patients are coming in. We, and I say we as a group of providers across the country, aren't doing as well as we need to do. and helping them understand what we plan to do, the cost associated with that, and how much personal responsibility they have. Now, it's not that we're not trying, it's just a very complex system. And so, again, I think as an academic institution, particularly with our population of patients we serve, we really need to focus on that and think about how we bring down the cost of care and reduce that burden of financial responsibility. What does it mean for us if we bring a patient into the hospital with a very severe acute illness and it costs hundreds of thousands of dollars, but we restore them to great health? And then when they go out of here, suddenly they have to sell their home, sell their car, they declare personal bankruptcy, they've lost their job. Their life has changed forever. And so we need to think about this, I believe, more globally and think about our responsibility not only in terms of being the fiduciary of the patient's health care interest, but being the fiduciary of the patient's life interest. So that's that part of the sermon. Let me move into the slides. All right, so changing models of reimbursement. We've talked about this, again, diminished dollars per unit of clinical service. There's a big move across the country. It's actually more prevalent on the east and west coast than it is in the central part of the country and in Texas. In general, we tend to lag the rest of the market rest of the country in terms of reimbursement changes, but eventually we catch up. So we're moving from a fee-for-service system in which everything we do, all the services that we provide to a patient, have a certain charge associated with them. It's been that way for years. But that creates perverse incentives for us as a provider, because the more we do, the more we charge the patient. And, well, then when you have private insurance, the more we charge the insurer, and just think about how that adds up over the course of time. So a number of years ago, a number of health economists got together and said, we need to change that system and get rid of those perverse incentives for providers to spend money for unnecessary care. So they came up with this concept of value-based care, which is not too dissimilar from capitation. Those of you who are around in the 90s remember that, where there was a single fee provided that covered all sorts of service to a patient or to a patient with a certain diagnosis. Value-based care is similar in a way to that, but not so much focused on limiting care as limiting the cost of the care provided. So across the country now, there's a huge move towards value-based care away from fee-for-service. Most people who are watching this trend don't believe fee-for-service is going to go completely away, but they think that places like UTMB need to have a foot in both camps, and probably with the bigger shoe in the value-based care camp as we go forward. So we need to be thinking about that, how we continue to provide high levels of care, all levels of care, very specialized care, but do it as economically as possible, and also how we begin to do a better job of taking risk, being willing to consider how we bundle our services for a fixed cost, and then with good information to our providers, manage within that cost envelope as we go forward. Accountable care organizations, ACOs, are one of the ways that organizations, providers, whether they be healthcare systems or physicians or other sorts of groups, approach the value-based care market. And essentially, they were originally focused on a Medicare population. Now they're more broadly focused. Typically, they cover the range of inpatient, outpatient care services. The primary care physicians play a dominant role. The specialists come along. Essentially, there are cost thresholds for different sorts of care. And the primary care physicians are the navigators, are the gatekeepers, if you will, and the specialists then work within the cost envelope for particular services to make sure that that cost threshold is not exceeded. And if there's a savings created, then many times the provider organizations benefit from sharing the savings. So in 2018, about 20% of the major employers who have employer-sponsored insurance across the country offered an ACO plan. This year and next year, the numbers are projected to go to between 50 and 70%. UTMB needs to be ready for that. We really don't have an accountable care organization approach to put in the marketplace. We have something that's like that, but we need to be bolder and more aggressive in designing those sorts of products and making them available to employers and payers in our marketplace. Increasing price and cost sensitivity. We've talked about employers. They're investing so much in paying for healthcare premium costs for their employees that they're not able to raise wages. That's a real problem, because then it becomes about competition for the worker. And so workers are looking for wages. The younger we are, the more we want in terms of compensation. The older we are, the more sensitive we are to benefits. So a number of employers are thinking about that. They've become very cost sensitive. They're trying to guide their employees to lower cost plans. They're also moving their employees into what are called high deductible health plans, which means that the deductible limit that an individual patient may have to meet could be $10,000 or more before the health plan kicks in. Remember when I talked about more personal responsibility for patients? A lot more of that is going on, and that trend is expected to continue to grow over the course of time. A number of small businesses are dropping coverage completely, saying, good luck, you're on your own. We don't have to compete for you and your services like some of the bigger firms, so we're just not going to provide health care. Well, then it becomes the employee's personal responsibility to either purchase coverage or go naked, if you will, and be at huge risk in case they have a catastrophic illness. A lot of other responses, the development of narrow networks. I've talked about this with some of you, so have our chairs and other strategic leaders in the institution. What narrow networks are smaller groups of providers. Think about those of you who have our UT Blue Cross Blue Shield plan. There are a lot of providers that are available to us inside our institution and outside. We have very generous out-of-network benefits, so essentially we can see any provider that we want to see and have most of our costs covered. Well, what the payers are doing now is looking at individual physicians and providers and looking at the cost of the care that that individual delivers and deciding whether they're in-network or out. And on the basis of that, designing much smaller groups that are considered in-network and eliminating then out-of-network benefits. So if we're high-cost providers, which most academic medical centers are today, guess where we're going to be? Out-of-network and not accessible by many of our patients. We can't allow that to happen. And so we need to be thinking about that and preparing for that, and particularly thinking about how we manage cost more effectively and provide that information back to our physicians and providers. Turns out, too, interestingly, that millennials, how many of you are millennials? Anybody want to admit? All right, well, thank you for being here. Millennials, you all are much more price sensitive, and you have a higher level of desire for transparency of cost. And this is from market surveys around the country. So as you make your choices, you really are diving into the cost numbers, and you also want choices in terms of what's done for you. You understand what the options are and what the personal financial responsibility is going to be. That's important. We need to take that into account. Baby boomers aren't so sensitive to that. Millennials in the country, by the way, now outnumber the baby boomers. Those of us who are baby boomers are dying off. So that trend is going to continue to grow. There's also much more of a focus on the experience of care. So what consumers, patients are really looking for is more of a retail-oriented experience. So they care about how we greet them, how we provide service to them, what our clinics look like, how they feel when they speak with us, when they walk into our offices, when they interact with us, and when they leave. So they actually aren't differentiating on the basis of quality of outcomes. Now, we spend a lot of time investing in best care, and that's very important because it's related to high value. What I'm really pointing out is if we neglect the patient experience across all facets of interaction, doesn't matter whether we're number one in the country or number 100, we're not going to get the patients that we need to serve our educational and research missions. So a lot going on, changing models of reimbursement, increasing price and cost sensitivity, and real consumerism, as we've seen with retail in the past, now beginning to come into patient choices about health care. I don't think we have to spend much time on growing impact of technology. A lot of stuff going on. Digital access, telehealth services, wearable and home monitors. By the way, in the next 5 to 7 years, it's predicted that 50 to 60% of the care we do on an inpatient basis today will move to outpatient care or home care, just on the basis of our ability to monitor what's happening with patients. And of course, that reduces the overall cost. The rise of personalized medicine, the scientific advancements with genomics, proteomics, other metabolomics, and our ability now to create a better predictive model for what happens with patients based on their genetics and their behavior, the interactions of the environment with their personal genetic makeup. Artificial intelligence. Now, I'm not talking about the Watson thing. I think most of us know that's been a pretty significant failure so far. It's getting better. But I'm talking about artificial intelligence that's being applied to data mining. Again, thinking about predictive analytics, helping us understand what variables really make a difference at the level of a population and down to the level of an individual patient. Robotic process analysis, RPA, being used in a lot of hospitals around the country in the revenue cycle to do coding, to do claims administration and the like. So a lot happening out there now in terms of the applications of technology. And of course, we're living at internet speed. So this is all going to increase in terms of its impact on healthcare over the coming years. More focus on population health and social determinants. And I've been saying for a while, I think this is a sweet spot of opportunity for UTMB, given the diverse nature of our patient population. There's so much we can do if we develop better analytics. We have great analytics today. We've made significant investment. But to really understand what drives disparities among the different patients and different populations we see, and then work with our providers to change the impact of those variables for our patients. So there's so much we can do on that front. I'm really excited. And it's really important. What percent impact does healthcare have on our individual health? Anybody know? Candy, looking at you. 5%. I knew you were going to say that. So all this work we do as healthcare providers, as institutions, has a 5% impact. So in other words, our system's really screwed up today because we're really focused on that 5% impact, knocking ourselves out. How much of an impact is it having? What percent is focused on our genetic makeup? We used to believe it was everything, right? Those of you in science. You know what it is? You know what it is, percentage impact? 30%. Guess how big of an impact where you live or work has? 15. So again, interaction of environment and genetics. But what's the biggest impact factor? Our behavior. 50%. Every time I mention this, Dr. Jeff Temple says, and Dr. Callender, you're not investing enough in behavioral medicine. I got it, Dr. Temple. So I understand that, and we do have to think about that. And you know, it's not just about having behavioral medicine specialists. It really is thinking about the breadth of delivery that with which we engage patients, and thinking about how we develop a system that better encourages and supports them in changing their behaviors. That's what's really going to reduce the cost of healthcare and make it a whole lot more accessible. A lot of other stuff going on, changes in employer approaches and offerings. I talked about the high deductible health plans, digital engagement. How many of you, by the way, with our University of Texas plan, over the course of, Dr. Walter's just going to go nuts when I mention this, you were signed up for an imaging study, an x-ray here at UTMB, and you got a call from Blue Cross saying it'd be cheaper if you got it somewhere else? Yeah, absolutely, a bunch of us. And that's really true, at least based on the way we've operated. Now, there are huge issues in terms of quality and the like, but this is the sort of thing that payers and employers are doing, and now it's becoming automated, where they're intervening as patients make choice about health care to drive them to lower cost providers, irregardless of quality metrics. So again, we just need to understand that and think about what our response is going to be as we go forward. I won't dwell too much on these others. Policy changes. This is just to remind me to talk really about politics. How much of an impact do you think healthcare and the management of healthcare is going to have in the 2020 election cycle? A lot of pundits say it's going to be the number one issue. If it's not number one, it's going to be near the top. And of course, we've got the big court case, Texas at the lead, a decision in the Fifth Circuit Court of Appeals about whether or not the Affordable Care Act is going to stand. And if it doesn't, it's going to be absolute chaos. And that decision is probably going to be announced about the time that we're either voting in the primaries or voting in the general election. So a lot of things happening around policy and politics. We need to be active on that front too. After all, we're the experts. The politicians aren't. Dr. Raymer will be the first to tell you the people writing the policies and the laws concerning healthcare typically are just a few years out of college, very idealistic with no practical healthcare experience. So, and that's not a knock against them. They're doing the best they can, but they need the benefit of our counsel and our experience to really try to understand the complexity and get it closer to something that truly works to improve health across the country. Interesting, the level of collaboration now between health plans and providers. You know, it used to be health plans and providers were constantly at odds. Oh, I hate United Health. They're awful. You know, Aetna just stinks. Now we figured out we need to work closely together. And if we do, we can leverage the resources that are available to us in terms of premium dollars, cost of care, and the like, to really begin to make better decisions and optimize outcomes. And oh, by the way, that risk thing, if we're working together, both major parties can manage the overall risk more effectively. So a lot happening on that front, and we need to be thinking about that and how we might partner with the payers, the health plans, as we go forward. There's likely going to be a lot of movement on this front. There are already joint ventures between some big academic health centers and some of the health plans aimed at creating specific products in a local market or a regional market. Those are the sorts of things, opportunities, or perhaps challenges that UTMB is likely to face pretty quickly. A lot of revenue tied to performance. Again, this is about the risk, about reward, about meeting cost thresholds or quality outcome thresholds. And if you can create a savings or achieve a certain level of outcome, then the reward is higher. And of course, that's a positive incentive. There'll be more of that as we go forward, but it'll become more complex because it's not just about us as a single institution. It's about how we collaborate with other providers, particularly those that you might have a skilled nursing facility or long-term acute care facility or home health facility, our group that's involved with us, and external community physicians. And those things would be variable over the course of time, but essentially will be put collectively at risk. And we need to figure out how to manage that with our revenue tied to overall performance. And if one of our partners really fouls up, we're going to bear a portion of the responsibility. So again, we need to think about how we manage that risk. Innovations as disruptions. You know, I love this one, the Amazon JP Morgan Chase, Berkshire Hathaway thing. And some people have asked me, well, what's the big deal? Well, for a lot of us, it just scares the holy heck out of us. Amazon is an incredibly capable organization. Did any of you just see that they're creating an alternative to college for their employees to make sure they're well prepared for what Amazon needs for them to do, as opposed to just getting a general education with an overall general skill set in a certain area of expertise? Fascinating. They have this thing called Amazon Web Services, which really is at the core of their interface with consumers as well as their distribution system. And so the thought is, with this group having over 1 million employees as a captive group, also with Amazon now purchasing a pharmaceutical supplier and its distribution network, that they can begin to really guide their employees into making good health choices, starting with the low-level stuff. So a lot of primary care, a lot of urgent care needs, those sorts of things, medication needs and the like. They can make those services immediately or near immediately available with the application of the cloud services capability and a provider network and a lot of telehealth tools. And so if they can do that, and then that can be emulated, and suddenly they develop that into a set of retail products, it markedly changes delivery of healthcare in the country. And those of us who can't do that or haven't done it, what are we left with? They're steering all the patients. They're doing all the low-cost stuff. What are we left with? The really high-cost stuff, without the ability to have any influence on which patients are steered to us. So think about the risk associated with that. So again, a lot of things to consider there, but it's happening. We need to understand that, think about what that is, and how we engage that over the course of time. You know, a lot of issues now with drug costs. I hate the drug companies has become a mantra for a lot of our candidates and politicians. Complex situation again. New high-cost drugs being developed that actually shorten the overall duration of care and can cure a patient, but providing an incredibly expensive episode of care. And the payment system's not designed to accommodate that. Just think about a patient with hepatitis C and the high-cost drugs that are delivered over a fairly short period of time. Patient has the disease eliminated, but now all of that payment's concentrated in a very short period of time. And a lot of payers, as well as employers, don't have a risk management system to accommodate that. Demographics and state policy, just to remind me, oh, by the way, Texas has about 4 to 5 million uninsured among the 25 million population in Texas, 20% uninsured, and we have no plan to deal with that. Now, again, I'm not trying to be too critical here or say I'm a D or an R, but it's just the nature of our state. We've historically been a bootstrapped state. We'd like to avoid the longer-term cost. We've been unwilling thus far to negotiate with the federal government to try to do something different, or maybe the political situation isn't judged to be best to do that. In any case, 20% of the patients, in our case higher, coming through our door have no insurance. How are we going to deal with that? What are we going to do? And again, think about the patient, reducing cost, trying to be engaged with them differently to keep them out of the emergency room, to keep them from developing complications of acute illness. We need to be thinking about that, have a better plan going forward for how we manage that part of our population. So other public health issues, just to mention that, we got the opioid crisis out there. Again, all kinds of behavioral medicine issues. Dr. Wagner, is it 40% of patients presenting for primary care have an associated behavioral health issue now? Is that correct? Okay. And that's significant. And Dr. Wagner and Dr. Barbara Thompson and their faculty members recognize that, and they're doing some innovative things to try to bring our behavioral health providers together with our primary care providers. I think we need to be more aggressive on that front if we're truly going to serve our patients well. So opioid crisis, we have a relatively small number of behavioral health specialists, so we need to figure out how to leverage them. over this tremendous need. And again, a strategic issue for us as we think about making behavioral health care more accessible and more cost effective. So, have I worn you out yet? There's a lot of opportunity, right? And I think we're a very capable organization. Are we going to be able to take on all of this all at once? No, absolutely not. But we're already making significant strides. We're certainly seeing the impact of these trends in terms of what's happening with our patients, the impact on our operational and financial performance. So it's all right there. And so now we just need to create a better approach, a more complementary plan, works together to address a lot of these needs and pursue these opportunities. So here's Calendar's recommendations, okay? These are just ideas. These need to be more fully vetted. Some of them are actually guiding what we're doing because we generally agree that they're the right thing to do. Others need further discussion in terms of how much we employ these approaches versus others to respond to some of these trends and do a better job for our patients. Now, I have to admit, some of these bullets are a word full and a head full. So let me just tell you what I'm really talking about here with this first one. So incorporate delivery models focused on populations and geographies, utilizing physical locations, provider groups, and digital health technology to provide comprehensive high-value care. What does that really say? Be patient-focused. Patients are different in every one of the geographies that we serve. The mix-up of the patients or the payer mix, the different population percentages are different. That's an opportunity. We need to understand that. We need to understand what those different segments of the population really want and need in a particular geography. We've got a lot of the geography covered now with inpatient facilities and outpatient facilities. Now we need to go back and think about, rather than one size fits all, what do we really need to be doing in Clear Lake and League City? How is Angleton different? How is Galveston different? Is there a difference between Texas City and Lamarck and what's happening in Friendswood? And how do we then manage or sculpt the delivery of our services so it's more patient-centered? Again, thinking not only about how we improve health, change behavior, but create the right sort of experience. And not just by inviting patients to good luck, make an appointment with us and wait 21 days. We have to engage digitally. We have to make ourselves more accessible. We need to change our approach to using providers, different sets of providers. Think about how we work better as teams so we can become much more patient-centered and respond to these population and geography-specific needs. Now, the second one, that's pretty obvious. We need to continue to grow the number of patients we serve because that's what buys us a place at the table, if you will. I talked about the threat to patients being directed elsewhere, and what we need to do to help counter that threat is make sure, again, we don't have to take anybody else's market share, but just keep up with the population growth in terms of having patients who identify UTMB as their primary source of health care. That's measured by the number of attributable patients, which is the definition associated with how many patients are in a value-based care plan, are unique patients in targeted populations. Donna, how many unique patients do we have today? You know? It's less than 200,000, right? Where's Becky? How many? A little under 200,000. So Memorial Hermann and Methodist have over 1 million. So and they're going to continue to seek to grow those numbers. And so we're roughly 20% of that size or smaller. So again, we're never going to be as big as those big systems, regionally dominant systems. But if we're more significant in terms of the numbers served, then it's more likely we can be at the table with them and others as we seek to determine how we best deliver health care to the people in Southeast Texas. The next one, another mouthful, sorry. Achieve success with strategies and operating plans that optimize revenue streams, balance of fee-for-service, and value-based care. Again, that's just trying to get it right in terms of what are we going to do that's fee-for-service based? What do we need to do in response to the market relative to products that are based in the value-based care approach? There are opportunities there with the Medicaid population, with the Medicare population, some privately or employer-sponsored insured populations that have commercial insurance. So, and we're working on developing those approaches. We just need to be more aggressive. Business intelligence, I think we're actually doing pretty well on this front. This is the basis for UTMB Discover. I pushed it a little bit here, saying a market-leading approach to collection and analysis of data focused on delivery of high-value care, analytics for optimization of operational and financial performance. We need to continue to invest there. Again, moving towards having information down to the level of a patient that we can provide to our providers and to the people who manage the health system that help us how to better engage them, lower the overall cost of care, and help them change their behavior. And the next one is just moving beyond where we are today with analytics. We do a really good job. There's this beautiful UTMB Discover app that's helped us serve our DSRIP patients very well, and now we're expanding its application into some of our community health opportunities that essentially is a checklist. Did we counsel our patients to get their flu shot? Did we make sure that if they have diabetes, they got their eye exam and their foot exam? And so again, just reminding us to make sure that we're doing those things that we know can improve those patients' health. But moving beyond that now to something that's more focused on clinical risk identification and intervention. Those of us who attended the Vizient conference last year saw an example of this. New York University has this incredible app that takes a look at older patients with higher risk scores and basically makes an estimate of how likely they are to suffer mortality within the next 6 months. Now, I know that sounds a little morbid, but if you have that information, you can manage that risk better. You also, for those patients who probably can't be moved too much off of a course towards the end of their lives, you can do a lot more if you understand that to make them comfortable and to have the appropriate palliative care so that their remaining time is as good as it can be. And so that's what I mean when I say systems that support clinical risk intervention with predictive analytics. And of course, over the course of time, we want to take everything we know about a patient and try to really develop a prescriptive approach for them. So when they leave a visit with us or they're interacting with us through digital technology, they have a prescription that says these are the things you need to do to optimize your health based on your individual risks. And if you don't do these things, here's what you can expect. The next one, again, leverage technology. We're trying to be more aggressive on this front. For years, we led in terms of telehealth and telemedicine. Now we still do well with the incarcerated offender population, but using very old technology. There's a lot newer technology, a lot of opportunities to change our approach, use phones and the like. And so we're trying to do that telephonic through telephone interface, smartphone interface, a lot of other things. We need to invest aggressively on that front. Thorough engagement of physicians and providers with specific role definitions. What this really means, provide that great information back to our physicians. Let them understand what's happening with their patients. Help them change their approach to managing individual patients, their panel of patients, based on real-time feedback that helps them understand the patient experience, patient satisfaction, outcomes in terms of the interventions or the suggestions or prescriptions, as well as understand the cost. If we can do that, then our physicians will be very well positioned in the market and avoid the peril of being excluded from narrow networks. These things, I think, all make sense. We need to continue to be focused on great operational management, reporting out regularly what happens with metrics that truly make a difference, that describe how we make a difference, as opposed to things that are just key performance indicators but really aren't helping us move the needle. And finally, just because things are happening so quickly, things are changing so quickly, that internet gig economy, we need to regularly review what we're doing. It's probably no longer suitable for us to have a 3-year strategic plan. Sure, we can look out 3 years and set a course, but it's likely we're going to have to change it at least on every 6 month to a year basis, just because things are happening that fast. So anyway, those are my thoughts. Again, maybe my prescription. Much more of this needs to be discussed. I think we're an incredibly capable organization. Donna Sollenberger and I were talking today. I think we're just going to have to get more aggressive and be bolder and be willing to take on more risk as we go forward. That's what our colleagues are doing, and we're going to need to do the same and work together, sometimes lock arms and hold hands and understand there'll be ups and downs. But if we don't do that, we're not serving our patients well. And I don't think we're completely appropriately fulfilling our role as an academic health center. So those are the thoughts that I wanted to leave you with about change and about what we've been doing, how at the strategic level for the institution we're processing some of these trends and trying to develop more specific tactics and strategies to go at them to make sure that we don't get behind. Now, just backing up to the whole presentation, again, congratulations to our 3 faculty members who have been recognized for their excellence in teaching. Welcome, Dr. Harlan. Ms. Allenberger, we're not going to let you get completely away, but we will wave goodbye. Things are moving along nicely with regard to our current plans, but again, based on what's happening around us, we need to try to avoid the natural human resistance to change, aggressively understand it's happening, and work to manage it so we can continue to be successful. As always, thank you so much for what each and every one of you do to serve our mission goals and help us be successful. It's amazing what our institution has accomplished, and I certainly believe it can continue to thrive despite these challenging market conditions. So let me just leave it right there and see if you have any questions for me. Totally depressed you, huh? Dr. Wagner, can you stand at the door and maybe pass out prescriptions? Well, again, I didn't mean to be negative. I just think these are things that we need to talk about and engage, not hide from them. We really can't get away from them. I know we have a lot that we're already trying to do, but maybe we can think a little more broadly as we move forward in terms of what's happening around us and how we better position this institution to weather the threats and do what it's always done, which is to step up and play a leadership role in terms of serving patients, providing education, and doing impactful research. So thank you.
Quick question, Dr. Allen. What do you see as the 5 years in the future? What do you predict in terms of consolidation, the major healthcare organizations, 2 or 3 major organizations providing this, a lot of amalgamation between smaller groups with those 3 major players? How do you see it?
So the question really is about what does the future look like? What does it look like at 5 years in terms of consolidation, affiliation, mergers, collaboration? We've certainly seen that in some of the big markets around the country. I think we'll see it in Houston just because of the amount of investment that's necessary to take on some of these challenges. I think for the organizations in Houston, it may be as much about bigger outside organizations coming in as opposed to a combination of existing organizations, but that's just a guess today. That certainly could change. I do believe that there'll be a lot more cooperation and collaboration. And as you all know, we've really been trying to do that. Despite the challenges associated with that, MD Anderson, Health Science Center, community physicians, we think we need to learn how to work more effectively with partners who are different. They think differently, they act differently, they offer different approaches than what we do, so that we can, when the time comes when we have to work together, we know how to do that well. So I certainly see that as a trend And I think we'll see a lot of that over the course of the next 5 years. All right, so there is one more thing. I think some of you know this already. I notified the people that I work with most closely earlier today that in about 3 minutes from now, at least by that clock, the Memorial Hermann Health System will announce that I will become its president and CEO effective September 1st. I'm sad because you all know that I love this place. I'm invested in it and its success. I love the people here. I consider all of you family members and friends. I know not all of you believe that based on my behavior at times, but that never has been an intent to disenfranchise or hurt anybody. For me, it's a marvelous opportunity to continue to work with the UT system. As you know, UT Houston, the Health Science Center there, is closely affiliated with Memorial Hermann. We've been doing some work with them as UTMB to think about how we collaborate along the lines of your question, Patrick. And there may be more opportunity for that. I believe Memorial Hermann is interested in that in terms of the 3 institutions in the greater Houston area, recognizing that need for cooperation and collaboration to be successful moving forward. I will continue to serve the official functions of the Office of the President until August 31st. In the meantime, the Chancellor and the Executive Vice Chancellor for Health Affairs, Amy Shaw Thomas, are working now to identify people who might serve as an interim president. Their recommendations will be presented to the Board of Regents at their August 14th and 15th meeting, and I believe at the conclusion of that meeting, they'll likely be able to name an interim president. And as soon as that person is identified, obviously we'll try to get them here if they're not here already, and get them engaged, understand workflows, moving around, meeting people, try to help them get up to speed as quickly as possible. And certainly we have marvelous existing administrative and faculty leaders. As far as I know, none of them are going away. They're the ones who are truly guiding the development of these strategies, the tactics, the programs, and response to these challenges and trends. So none of that will change. I will put out a little global statement in just a few minutes also. The communications folks will release that. That just reiterates my thanks to all of you for the opportunity, the privilege to serve in this role over the past 12 years. It is an amazing place. I don't believe there's an academic health institution in the country that's any more capable than UTMB. And I expect that to continue to be the case going forward, so don't let me down. And of course, this institution will have a special place in my heart forever, and I will continue to support it and encourage it as much as is humanly possible. So again, thank you very much. Thank you for coming today. Thank you for being tolerant of me, not only presenting my thoughts today, but serving in this role over the past 12 years. And again, I'll be around till the end of August, so we'll have some other times to talk about other things. But I didn't want to make that announcement today so we can start the process of moving forward to identify an interim leader and eventually beginning the search for the next president. Thank you very much.
UTMB Health, working together to work wonders.